When a high-performance engine is pushed past its thermal limits, pistons expand, lubrication burns off, and gears seize up until the system locks. Sexual dysfunction and relational distress operate on this same mechanical logic, presenting as a compounding, multi-axis system failure. Reversing this gridlock requires recognizing three distinct axes failing simultaneously: cognitive interference, relational detachment, and autonomic nervous system dysregulation. The integrated sexual therapy protocol is a multidimensional intervention designed for complex cases where localized treatments have failed. This protocol is powered by the DZIRI HYPNO-SYNC SHOCK model, a structured 5-phase progression. This pipeline moves resistant, stigmatized patients out of performance paralysis and toward integrated intimate competency. Localized fixes often push the pressure to another part of the system. True resolution requires a systemic architecture. Intervention begins with Phase 1, permission. Using the PLICIT model, the therapist establishes a clinical baseline that neutralizes the shame blocking an honest assessment. Granting the patient control over disclosure builds the therapeutic alliance necessary for the phases that follow. This manual provides the framework for Phase 2, differential diagnosis, ensuring every case is measured against standardized clinical benchmarks. We distinguish between benign interests and pathology. A paraphilia is an atypical sexual interest that is ego-syntonic, aligning with the patient's self-identity, and does not require intervention. We contrast this with a paraphilic disorder, which carries specific diagnostic requirements. A disorder must result in clinical distress, functional impairment in social or occupational areas, or involve non-consensual harm. Clinicians must rule out organic etiologies, verifying that the patient's hormonal, metabolic, and vascular systems are not the primary cause of the dysfunction. Precision in diagnosis is the prerequisite for intervention. Filtering out physiological and benign noise allows us to target the psychological pathology directly. Once pathology is isolated, we deploy a tripartite intervention plan: cognitive behavioral therapy, sensate focus, and emotionally focused therapy. The primary CBT target in this protocol is spectatoring, a state of mental detachment where a person monitors and evaluates their own physical performance during intimacy. This self-monitoring spikes autonomic anxiety, constricting peripheral blood flow and making physiological arousal difficult to maintain. To counter this, the protocol utilizes sensate focus. Developed by Masters and Johnson, it remains the clinical standard for graded exposure to touch. The early stages of the protocol involve a clinical plan introducing genital touch over several weeks. This replaces performance metrics with sensory curiosity, asking the patient to focus only on temperature, pressure, and texture. Removing performance demands allows the autonomic nervous system to shift from a threat response to a receptive state. We then address the relational axis, using emotionally focused therapy to rebuild the underlying attachment foundation. Distressed couples often fall into a pursue-withdraw cycle, a pattern that reinforces emotional distance. In this cycle, the pursuer demands connection, but these demands often mask a core fear of abandonment. The withdrawer responds by shutting down, a defensive move that masks a fear of inadequacy or failure to meet the partner's needs. EFT structuring de-escalates this cycle, allowing partners to access and express these vulnerabilities in a safe environment. Physical intimacy depends on this foundation. Establishing emotional safety is a requirement for physical connection. Phase 4 introduces third consciousness, using mental simulation to solidify clinical progress. Lucid dreaming provides a neuroplastic environment for behavioral rehearsal, as observed in sleep laboratory studies. During a lucid dream, the prefrontal cortex remains active, allowing for conscious awareness and control within the dream state. The patient safely simulates intimate scenarios to practice regulating their physical arousal without the real-world pressure of performance. Within this state, we monitor for the circuit breaker phenomenon. Sudden spikes in anxiety or emotional overarousal trigger this circuit breaker, leading to a premature awakening and the end of the simulation. Patients practice recognizing these autonomic spikes and stabilizing the dream, learning to maintain calm during arousal. Rehearsing these responses in the dream state builds neural pathways that lower autonomic reactivity during waking intimacy. The 5-phase DZIRI transformation model acts as the operational sequence that organizes these established therapies. D for Discover involves the initial values mapping and rigorous diagnostic filtration of the patient's history. Z for Zero Noise targets the cognitive interference identified in CBT and the early stages of sensate focus. I for Inner Sync utilizes the shock point to create a pattern break in the patient's existing behavioral loops. R for Resonant Gratitude focuses on reframing meaning and aligning the mind and heart toward a stable future. The final I is Identity Installation, cementing new behaviors through neural simulation and repetitive practice. The DZIRI matrix sequences these evidence-based modalities, organizing the intervention for higher clinical efficiency. The intensity of these techniques places a rigorous ethical burden on the practitioner. Clinicians must apply absolute exclusion criteria during the patient selection process. Active addiction, untreated PTSD, and acute psychosis are automatic disqualifiers for this protocol. The protocol must be suspended immediately if the patient experiences traumatic recall or panic during a session. When safety is established, the clinician follows the DZRI signature sequence to drive the final transformation. This sequence moves the patient from the initial disruption of defensive patterns to the integration of a new intimate identity. By adhering to this pipeline and its ethical boundaries, clinicians transition from symptom management to a state of integrated intimate competency.